I would now request Dr. Karshit Joshi to introduce our next speaker, please.
Thank you so much. Now we have Dr. Jimit Vadgama sir from Surat, who is consultant diabetologist, fellowship in endocrinology, diabetes and metabolism, Swaminarayan and diabetes and hormone clinic Surat. Dr. Jimit sir, please.
Good afternoon, everyone. At the onset, let me first thank you, Dr. Mayur Patel, sir, and my old, very good friend, Dr. Yes Patel, for inviting me for this wonderful conference. Though we are meeting virtually, I hope we all will have a wonderful academic information being exchanged here. Today's my topic is pioglitazone, past, present, and future. It's a time to remember a forgotten diabetes medication. So it is very, very important drug and it has gone through so many controversies. We'll see a little bit about past also, present also, and future also. So we know pioglitazone, it was approved in US FDA by in 1919. In 2005, results of one of the first proactive trials that have shown macrovascular benefits of a diabetic drug, and it was a wonderful result. In 2007, again, US FDA has released safety alert and box warning for about congestive heart failure with pioglitazone. In 2008, Pio has become 10th most prescribed drug in the US. And in 2010, proactive studies showed some amount of increased risk of bladder cancer very early in the study, even with minimal exposure to pioglitazone. And FDA has started a ongoing safety review. In 2011, FDA approved the label change for bladder cancer. A warning was given. And in 2012, it was generic pioglitazone was also approved by US FDA. 6-year follow-up of proactive trial showed no association with bladder cancer in 2012. So in India also, drug was approved in early 2000. Pioglitazone was banned by Indian Health Ministry in 2013 due to some reports, and scientific evidence was ignored before banning the drug. Though it was only very few, 8 cases of bladder cancer that led to ban in India. Government had taken the decision in good faith, but again, and it was reviewed by Drug Technical Advisory Board in 2013, and it has recommended that the drug has been removed and it was again available. Why it is required? For years, there is an intense debate that insulin resistance or insulin deficiency. For Indians, insulin resistance is the primary defect in type 2 diabetes. So this is very, very important. And this is also important for reducing the CV risk. We are not talking about already established atherosclerotic cardiovascular disease. We are thinking about preventing the cardiovascular disease. So we all know about nurses' health study that has shown that elevated risk of cardiovascular disease began even at least 15 years before the diagnosis of diabetes. So that insulin resistance is the main thing and reason for atherosclerosis. And if you treat insulin resistance, you can prevent atherosclerosis or cardiovascular disease also. And the results were also found in proactive studies. And we know what are the options for insulin resistance treatment: diet, exercise, and weight reduction, and also drugs like metformin and pioglitazone. But we all know metformin only acts on liver, and it is not a true insulin sensitizer at pioglitazone. Why? Pio acts on all 3 main organs for glucose regulation. It also acts on adipose tissues also. It acts on skeletal muscles also and liver also. Skeletal muscle increases the glucose uptake. In adipose tissue, by PPAR gamma activation, it increases the adipogenesis, increase fatty acid uptake, increase lipogenesis, and increase glucose uptake. That's the reason it reduces fatty acids in plasma, and it is one of the main mechanisms for beta cell protection also. And in liver, it reduces the gluconeogenesis. But metformin only acts on liver. By all 3 mechanisms, pioglitazone reduces the hyperglycemia. It's very, very important. And this is why pioglitazone is the potent and true insulin sensitizer. Okay, we all know we Indians are thin fat Indians. We though as compared to Caucasian here, we have similar BMI. But if you see, our Indians have more body fat. Asian Indians have more body fat and lower muscle volumes than other ethnic groups with comparable BMI. So we have more insulin resistance. That's why we require drug targeting insulin resistance. But do treating insulin resistance help? Yes, we have so many evidences with pioglitazone that it is anti-atherogenic in cardioprotective effects due to treatment of insulin resistance via pioglitazone. We have so many evidence. We have 4 randomized controlled trials also like Proactive, Chicago, Periscope, and IRIS trial. We have several meta-analyses also. We have large 3 observational studies from UK also. So we have plenty of evidences with pioglitazone, and these are comparable to even current newer generation SGLT2 CVOTs also, because the number of patients are too high. Proactive studies significantly show that pioglitazone reduces the recurrent fatal or non-fatal MI by 28%, acute coronary syndrome by 37%, and secondary stroke in patient with previous stroke by 47%. So lessons from Chicago and Periscope trial, we have seen that pioglitazone, if you give, it reduces the coronary atherosclerosis also, and even the reduces the carotid intima thickness also. Atherosclerosis regression or prevention of the cardiovascular disease is a very, very important thing, and the mainstay why pioglitazone should be given to reduce the CV risk. IRIS trial also, it was given for non-diabetic patients but with insulin resistance, and it given for stroke. After stroke, recurrent stroke was reduced by 24%. Myocardial infarction was reduced by again 24%, and new onset diabetes was reduced by 52%. So huge reduction in the number of event by just by treating insulin resistance. So first time a therapy directed at insulin resistance has shown to prevent cardiovascular and cerebrovascular events for these patients. So this is for prevention. We are all talking about SGLT2 inhibitors and GLP-1. They reduce heart failure and cardiac death, but they are in patients with established cardiovascular disease. All our patients are not like that. We need this kind of treatment which prevents our healthy patients for getting cardiovascular disease, and they reduce the CV risk. Our beta cells. In my point of view, only pioglitazone has so much long durability because it preserves the beta cell. We know UKPDS trial has shown that 50% of beta cells are already lost at the time of diagnosis of type 2 diabetes. And if we give sulfonylurea, we have seen the HbA1c reduction that is not maintained over a period of time, and your HbA1c again goes up. But with pioglitazone and even with rosiglitazone, we have seen so good durability data, and many of our patients are taking just pioglitazone, low dose, and metformin for years and years, and their sugars are well in control. So durability is very, very important. What about non-alcoholic fatty liver disease and NASH? We know diabetic patients and obese patients, NASH at high risk of cirrhosis and hepatocellular carcinoma in future. And NASH are markedly resistant to insulin. They have a similar mechanism, and often they have metabolic syndrome and also increased risk of future cardiovascular disease. And multiple studies have shown that pioglitazone consistently reduces hepatic fat and even reverses the hepatic fibrosis also. So we have a good amount of evidences for NASH and FLD, and it is one of the only drug that has histologically proven regression in the NAFLD as compared to other oral drugs for diabetes. Bladder cancer controversy that has put this molecule in highlight also, and now towards the side also in our algorithm. So after proactive studies and banning from other countries, US FDA also done a 10-year follow-up and for bladder cancer. It was agreed upon by US FDA, and that is study involved around 2 lakh person and 40 years of aged 40 years and older, and who were diagnosed with diabetes and maintained, and they were followed till 2012. And our use of pioglitazone was not associated with development of bladder cancer. For around 2 lakh patients, no bladder cancer. Okay, and several additional studies and reports finding that pioglitazone does not increase bladder cancer. There are many studies from India also. Okay, what is the present of ADSAs? You can use it everywhere, even with patient with high ASCVD risk or established cardiovascular disease also you can use, because proactive studies have shown benefit. You can use in CKD also, but there is risk of fluid retention, but no dose adjustment is required. If there is need to reduce hypoglycemia, even you can use the pioglitazone in all category they are given, because it doesn't cause hypoglycemia alone. If there is need to minimize weight gain, then you definitely it is a lesser or least frequent choice, and its cost is also an issue you can use, because that's why it is the required drug in India, because we have cost also a major issue, and we have insulin resistance also a major issue, and that's why this drug should be on the top of priority of your patient. The last, what about future? And just what about, I'm saying, I'm leaving you with this article as my last slide. That is an article by DiFranzo, and it has shown, DiFranzo had said pioglitazone is the forgotten, cost-effective, and cardioprotective drug for type 2 diabetes. So we all know this all controversy going on. Pioglitazone has been forgotten, but remember it is cost effective. It is effective for glycemic control also, and it is a cardioprotective drug. Still, we are not using because of advent of newer drugs and marketing. We need to remember this, and future is, though in my point of view, it is bright. And who wrote the article as a co-author? It's Stephen Nathan, who has written the article that led to ban of rosiglitazone, and he himself is saying that remember this is a good drug, it is cost effective and cardioprotective. So I thank you everyone for listening to me. If you have questions, we can discuss. Thank you again, everyone.
Thank you so much, Dr. Jimit Vadgama.